Good afternoon, everybody. Thank you all for being here. Really appreciate you taking the time. We have a terrific session today. We have two phenomenal speakers, Suneet Mittal and Arnaud Rosier, and I'll introduce them separately just before they speak. I'm Jag Singh. I'm from Mass General Hospital in Boston. Our session today is really about enhancing patient care and reducing the workload using AI-based remote monitoring. So a little bit of a tongue twister, and we have sequential talks that'll help you outline how we can use AI to help reduce workload and reduce false positives. At least that's my topic, is really using AI to reduce false positives from ILRs, from implantable loop recorders. What are the real-life implications? These are some of my disclosures that may or may not impact the talk. Having said that, my talk is going to be largely an overview about data overload. It's a problem. Very briefly, I'll talk about remote monitoring, and then Dr. Mittal will take it on from there. I'll touch on the aspect of the issues of false positives, which we think and we know is a big problem, and how AI potentially can be a solution to dealing with that. Now, as we think about all the devices that exist that can provide information regarding heart rhythm, there are a multitude of wearables out there. But we're not going to talk about wearables, but you can only imagine that if we can't fix it for implantables, we're going to have a problem with wearables. So I think some of this talk will eventually also show or start giving you directions as to how we need to deal not just with wearables, but today we're going to talk only about the implantables. And for my talk, I'm only going to talk about implantable loop recorders. And as you can see out there, they come in different shapes and sizes from different companies with different algorithms and different extents of false positives based on the nominal programming. So I'm not going to belabor this, but I think remote monitoring is really an important component of care, right? Especially when you look at the operations, and Suneet will understand this very well, when we look at the operations within the cardiology division, remote monitoring, which was considered a small portion within the outpatient care, inpatient care, ambulatory care, care with the outside centers and satellites, is now largely going to become a large remote monitoring center that can bring all this information together. So the care will be remote. It will be aided by sensors. So the sensors out here are the digital devices, or the ILRs we're talking about. Much of this will be driven by AI, which again we'll be talking about today, and will be incorporated in sustainable workflows, much about which we will be talking about today. So that's the future of care, actually, is sensor-aided care, which is delivered remotely with AI and which is incorporated into your workflow. So that's really important to recognize. So let me focus on the ILR issue. I think we all know that there are a spectrum of indications for ILRs. The most common ones include cardiac arrhythmias, which we'll talk about today, but also cryptogenic stroke and syncope. And remote monitoring really came up with the idea of really reducing the burden by easing the workflow and enhancing arrhythmia detection. But the big problem out here is that there's a high alert burden. And this high alert burden, much of it can be false. That actually lands up enhancing the burden and becoming a bit of a pain. Now, I don't have to tell you that false positives are really very common, and the burden is real. There's a fair amount of data out there, multiple publications, and I'm not going to belabor the publications, but I do want you to know with nominal settings, depending on whichever device you're looking at, they can be 46 to 86% can be false positives that come from these devices. And that's why you need AI-based strategies that can help parse through these and really separate out the true positives from the false positives so that it can make it easier. So that's one of the reasons why you need AI, is to really take away those repetitive tasks, eliminate the non-actionable alerts, right? But beyond that, I think it's really important because it has to reduce the false positives, because when you get a false positive, your patient can find out that they had, let's say, AFib detected. It enhances patient anxiety. It also enhances clinician burden, and therefore you need AI to reduce that patient the burden as well as reduce the anxiety. And then there are also many other ancillary benefits of AI, and that is reducing the practice variance, reducing the cost, enhancing the efficiency, and we'll talk about that in the next few minutes. I'm not going to belabor what AI is. I think everybody really knows that artificial intelligence has various subtypes, and one of the biggest subtypes includes machine learning. And machine learning basically involves large data sets and developing algorithms that solve problems from those data sets. And a subfield of that is deep learning. And deep learning really amounts to relating complex data sets to labeled outcomes and then using deep learning with, I would say, computational neural networks and layers of abstraction and layers that mimic brain-like activity to really show an association and find a mechanism to prove what the other end of the ground truth is through these different strategies that we just talked about. And that's what AI and the ILR really, so to simplify it, I would say AI has this ability to see more than what the human eye sees. But for ILRs, it sees more than what the conventional ILR sees. And if you look at this nice little ECG strip out there, it is detecting the T wave oversensing, and it's interpreting that as ventricular tachycardia. But if the machine learning, if it looks at it largely, it can see beyond just the individual complexes and can look at the pattern as a whole, can actually relabel this and call it a normal rhythm by just relabeling the T waves without actually being represented as ventricular tachycardia. Similarly, for atrial fibrillation, you have conventional algorithms for atrial fibrillation that use RR irregularity, use P wave duration and formation. And there are deep neural network strategies that can help tease those out and help determine which are false positives and which are not, using some of the deep learning strategies that we just talked about, just as deep neural networks. So the DNN filter, and this is work done by Suneet, by Dr. Mittal, where working with cardiologs, he looked at what the impact of a DNN filter would be on the regular episodes that are depicted out there. And you can see, I don't know if I can show it you out here, you can see out here that with the DNN filter, the false positives, the positive predictive value gets enhanced significantly out here. And if you look across, and this is for atrial fibrillation, and when you look across the duration of atrial fibrillation, you see that the bang for your buck is largely for shorter duration of atrial fibrillation, which is more difficult to detect, and therefore having these DNN filters. Now, the DNN filters have different ways of working. They have a QRS filter, and they have a P-wave filter, and they look at 10-second aliquots to really detect atrial fibrillation, but they're able to enhance the positive predictive value depending on the duration of atrial fibrillation. And the most bang for your buck you get is when there's shorter atrial fibrillation, when you can have many false positives. Now, keeping that in mind, it actually lands up changing the workflow, and you can see rather than all these outputs going directly to the clinician, they first go through the DNN filter, and from the filter, they then get dispersed into those that are now truly positive versus those which are false positive, and the clinician then gets the ones, the real actionable alerts to look after. So this is the same with, can be for specific, device-specific AI algorithms, and this is the confirm ICM, and you can see that using an AI algorithm, you can actually reduce the number of false positives by 98% for all the arrhythmias, and significantly so for asystole and atrial fibrillation and all the others that you can see up on this slide. So using AI can reduce these false positives and actually help reduce the physician burden or clinician burden for sure. So this brings us to the Implicity platform. And what this is really cool about is that it actually has an ILR ECG analyzer. And the output from the manufacturer platform comes directly into the Implicity management platform. And using a proprietary AI algorithm that has been trained, it's then able to reclassify patients, whether they're false positives or true positives. And this can be actually nicely seen in this study, which was presented at the Heart Rhythm a couple of years ago and published in Heart Rhythm, and really shows you that when the study was done on the Medtronic Reveal link, and there were 31 sites studied, which 455 patients, and 695 recordings were considered abnormal. These were then adjudicated by a committee, and they were tested by the AI algorithm, and there were 31% of these were false positives that came down. And after adjudication by the AI, 79% of these false positives were adjudicated as correctly, so really kind of reducing the burden to the ones that actually the physician had to read out there. And that was just to show you that the specificity varies by the type of arrhythmia, and the specificity obviously is the lowest for atrial fibrillation because of the duration element that I just talked about too. The question comes up is, using AI, does it take more time? Does it impact the time in how this comes across to the physician? And this is, again, a nice study done and presented at the ACC last year, where, again, 2,610 episodes were recategorized, of which 34.4% of them were found to be false positive, and the time duration of the whole operation was measured and found that there was really no time difference or adverse effect on the time to detection of ATAF episode using artificial intelligence strategies. So when you look at the ILR and Implicity and the AI algorithm out here, the ILR ECG analyzer reduces false positive episodes by 79%, while maintaining a sensitivity of 99.3%. And this novel AI algorithm significantly reduces 1/3 of the quantity of all episodes that have been flagged as normal, as abnormal. So really reduces the burden significantly out there. And this novel remote monitoring AI algorithm was able to reclassify 34.4% of all the ATAF reported episodes with no adverse impact on the detection of the first validated ATAF episode. So really significantly reducing the burden for the clinician out there, and also potentially reducing the anxiety for the patients. This is just to show you that there's a natural extension. You're using AI to help detect which are false positives and true positives, but you can also use AI from the ILR recordings to actually predict which patients will go on to develop arrhythmias. And this is work done with cardiologs again, which looked at 14-day holters, and from the first day you could predict which patients were going to develop atrial fibrillation over the next 13 days using deep neural networks and machine learning strategies out here. With that said, we actually have a late breaker today, exactly using the same thing as predicting ventricular tachycardia in the next 13 days after the first 24 hours of the recording from a 14-day holter. And the same thing is applicable in the future to ILRs, where you can predict which patients may actually develop arrhythmias in the future based off the early recordings. So my take-home points are that the data deluge is real. Data overload is really a problem. I think ILRs contribute to this problem as much as they would actually serve to help us. And I think false positives certainly add to the anxiety and burnout, and AI-based solutions, and especially integrated solutions with universal platforms, are the solution for the future. So I thank you for your kind attention. And we will move on to the next speaker, and that's Dr. Mittal.
Steal that clicker from you.
I'm going to start you up here.
Thank you. All right, thank you very much. It's always a difficult task to follow Jag on stage, so Arnaud, thank you for slotting me in the middle. But thank you to you and Implicity for hosting this symposium. And my topic is to talk a little bit about the new direction in the management of AF alerts and disconnected patients. And it turns out that this is a very timely topic we're having, because literally in the last 30 minutes, the embargo has been released on this guideline statement. So the HRS 2015 was the last time we had an expert consensus document on essentially device-based care. This document has just been updated, and literally in a session that's going on at this time is being presented. And so what I'm going to do is give you a sneak preview of this document, focusing in on this area of disconnectivity and alert management as conveyed by the experts. So interestingly enough, the guideline document has 11 take-home points. And what I've done in red is highlight for you all of those take-home points that directly are related to the issue of connectivity and alert management. And what you will see is that half the important take-home points are related to just these two concepts in particular. So the first one is that prompt patient enrollment and maintenance of regular connectivity with long-term adherence to remote monitoring accomplished by individual patient and caregiver education is essential to an effective remote monitoring program. And programming alerts specific to device type and indication with established mechanisms for promptly dealing with high-priority alerts can moderate increasing data volume and workload for remote monitoring programs. Use of third-party resources such as Implicity may offer financial and practical benefits for dealing with increased device clinic volume. ILRs require immediate connectivity to remote monitoring with special programming needs based on the patient's clinical indication for the ILR. And again, importantly, that alert-based remote monitoring relies on continuous connectivity, allowing for extended time intervals between in-office device interrogations. So let's talk a little bit about continuous connectivity. Again, just like the 2015 document, this document again says that as a class 1 level of A evidence in a letter A indication that in patients with CIDs, remote monitoring is recommended as part of the standard of care, so no change there. But what's very interesting is the new level 1 recommendation shown as bullet point 3, which establishes that in patients with CIDs on remote monitoring, with a device capable of continuous connectivity, connectivity should be maintained. So again, highlighting how important it is not just to enroll patients in remote monitoring, but ensure that they're connected. Now we know consistent connectivity depends on appropriate functioning of the remote monitoring home device, as well as on the telecommunication system availability and patient adherence to the follow-up plan. And that connectivity is critical to maximize remote monitoring benefits by early detection of actionable events, allowing for early intervention for arrhythmia and heart failure decompensation with potential to improve patient outcomes. But the reality is this is just not that easy to do. Now, one of the important advances in this guideline document is this here, again, a level of evidence 1, is that for the care of patients with CIDs on remote monitoring who lose connectivity, it is recommended that clinics have an established process that includes dedicated clinical staff to facilitate reconnection. And this is an area that Arnaud and his company have thought about quite a bit. And you will hear in his lecture, some of the approaches that they're using to reestablish connectivity with these patients. Now, connectivity is not that easy to do. We know that rapid management of these patients is imperative. It's important that every reasonable effort be made by the clinic to reach the disconnected patients. And again, Arnaud has some beautiful data on what those mechanisms may be. We know that manufacturers need to be better collaborative partners by assisting us, by notifying us who's disconnected and providing potentially technical support to get patients reconnected. And again, for the first time, the document recognizes, and this is important for hospital systems to recognize, that all of this takes time and effort, and that we need to be budgeted for adequately trained non-clinical as well as clinical staff who can actually deal with this important task. Now, my colleague Advay Bhatt's going to share these data at HRS, and I'm just sharing these with you just to highlight an important point, and that connectivity is not that easy to maintain. This is data from our practice looking at 90-day patterns of connectivity in our patient group, showing that there are day-to-day dips in connectivity. And when you look at patients followed over time, only 1 in 4 patients are continuously connected over that 90-day period of time, and almost 1 in 5 patients are disconnected for more than a week at a time. So although the guidelines are suggesting that we need to connect patients, the reality is this has been very difficult to do with current systems. I want to shift a little bit now, is that if you have found a perfect way to connect your patients, then you have to think about how are you going to use alert-based remote monitoring in these patients. And one of the big changes in the guidelines that now is that they are recommending, irrespective of whether you have a pacemaker or a defibrillator, that you may not need to see patients on an annual basis. You can see patients every 2 years in the office, assuming that you have patients on remote monitoring who are connected and are transmitting their data. And again, this will again put more pressure to try to ensure that we're adequately connected with our patients. The guidelines also highlight how we should be programming alerts and what we should be thinking about. On the right are things that is shown in red that should be prioritized: ICD shocks, battery information, impedance information, and other things like anti-tachycardia pacing and high thresholds, and give very prescriptive recommendations on what to do in terms of programming for patients with ICDs, pacemakers, and CRTs. But let's talk a little bit about loop recorders, which has really been the focus of the conversation today. Again, I'm going to highlight the bottom statement, which is really a statement that says, get these patients connected on remote monitoring. And in fact, you don't have to see them at all in the office. That it should all be alert-based programming, but with no need for routine in-office follow-up. And this will, again, be an important paradigm shift in how we manage all of these patients with loop recorders. Also, the guidelines give very prescriptive recommendations on how alerts should be managed, both red alerts as well as yellow alerts in these patients, really highlighting that really decide what needs to be, that you should be notified for immediately to try to minimize some of the data deluge implications that Jack spoke about earlier. Now, finally, 2 important points to leave you with. One is the guidelines recognize that patient engagement in this process is very important. It just can't be on us to make sure that patients are disconnected or connected. Patients have to be active participants in this progress, and hopefully, as more sophisticated apps become available to patients, they will have knowledge not only about their connectivity status, but will be able to troubleshoot their systems on their own to get themselves reconnected when they're disconnected. And finally, I think the guidelines for the first time really recognize how important it is to create an adequate infrastructure to do all of this. On the left is the recognition that we have to have specific personnel to do the various tasks that are involved in remote monitoring, and that involves ancillary staff. It can involve nurses and techs, device technicians, and with the physicians and APPs only being responsible for those things that are really at the top of their license, and really segmenting the work involved into appropriate categories. And on the right, really recognizing that you have to find the right team-based organizational model, and if that involves the use of a third-party vendor, then that should be really encouraged to ensure that you can handle all the tasks with remote monitoring. And for the first time, actually also starts to give discrete recommendations on staffing requirements by saying, and I refer you to point 4, that it's reasonable for clinics to have a minimum of 3 full-time equivalents for every 1,000 patients on remote monitoring, and that should comprise both clinical and administrative staff. And I think that as you read through the entire set of guidelines, you'll see lots of advances in thinking about how our thoughts in this issue have evolved over the last 8 years. So with that, I'll stop, and I'm going to turn it over to Arnaud, who's going to give his perspective on how he's gone about trying to address some of these unmet needs. Note.
Thanks a lot. That's very inspiring. I haven't been able to see these slides before, obviously, because this was embargoed till less than 1 hour ago. So it's a lot to unpack. It's very interesting. I think, one of the takeaways is that the community of physicians basically double down on the quality we need to have. And we are now basically asking for resources, right? We are saying basically, if you want to do remote monitoring well, you may need as little as 3 full-time personnel for every 1,000 patients. So I'm running the math right now in my head. And it's going to be super difficult to get that, right? I mean, some of us has like 5,000, 10,000, some have more than 50,000. So it's going to be quite an army of, I mean, probably we won't have these people, but at the same time, it makes a lot of sense that if we want to do remote monitoring with quality, we need to, push in that direction. So my perspective is, how can technology help scaling that? Because we can add more healthcare professionals. We can hire more nurses and train them. We already lack this. We lack this in all our departments. We want more nurses, more trained nurses and technicians. We cannot hire them. They are leaving, right? So how can this be done? So 10 years ago, maybe 15 years ago, my perspective already was, how can technology, and not just humans, help on this as well? And I'm not saying you should not hire these people. I'm just saying we may need both, actually. So in the past, most of the evolution of the field we saw was basically new innovation in devices. And we keep seeing that a lot for complex ablation, but we saw such amazing algorithms developed for, IPG and then CRT and everything else. And obviously, classification for tachycardia. The current revolution is really about data flowing. So it's about connectivity. It started probably close to 20 years ago still, but we are still seeing all that this connectivity revolution means in terms of more data. You say data deluge, data tsunami, right? More data coming through, which should be a good thing, but it's sometimes not, because we have to basically triage it. And I want just to ask, what is the future? What is the direction that not only we are going to face, but we may want to take in some place? And I'm going to answer that in a few seconds. But you have to figure, and based on your guidelines, people may ask things that are not what they should ask for. We are asking for more people, more staff. We say we need more money to handle these patients. And I really think some of it is true. But maybe this is not exactly what we want. Maybe what we want is actually stop managing, things that are mundane, some doing just administrative stuff, stop having to call patients for them to be reconnected because it should be handled with some other ways. And I thought it was a nice quote to have on that perspective. So let's try to keep in mind what we want. We want, in the end of the day, to deliver better care. That's what we want for sure. We probably want, in order to deliver better care, to know what should be done, so to have better knowledge. And for knowledge, we need access to data. But we probably want to save time because we don't have enough resource for doing anything else that we need to do. We probably want something connected to EHR, but in the end of the day, that's just to save time, right? That's not to do the rest. So that's an enabler. We want to reuse data for research, so that's probably more important, because if we don't have the knowledge to decide, we cannot deliver better care. But we also probably want to capture billing, because if we don't capture billing, we don't have the resource, and that's a loop. So we won't be able to deliver the better care in the end of the day. So I guess save time and delivering better care while capturing billing is the most important first. And you probably want, when it comes to remote monitoring, to get to that point when you're going to internalize it. I'm not saying service is bad. I think you may need service at some point, but if you're leaving on the table the technical fee, which is going, down and then up again, maybe at some point, you're going to have a less optimal situation when it comes to resource. Again, it's resource-wise. You need your staff. If you want to drive things through quality, you probably want to manage everything internally. If you want to manage things internally, unless you get your free full staff employees per 1,000 patients, you probably need a universal platform. There's no way you're going to cope with that if you don't have the best tools around. So with Implicity, we started doing this 7 years ago. I tried to fix my own pains. And then, over the years, we developed additional features. You have a bunch of solutions in this room of different companies, different industry players, which everyone have a kind of a similar approach on the first layer, which is going to be, get access to data, have everything in one spot, so it's going to be more convenient to at least do the reports and do the billing. And as I said, doing the billing is extremely important, and people have to be aware that most of the centers across this country, they bill for 20% of what they should, even now. That means they leave resource. It's not money, it's resource on the table. That leaves capability to handle patients better. So even if it's not what we were trained for, at some point it's our responsibility as physicians or head of teams to get access to the resource we need in order to deliver the best care. So I guess it's part of this picture. But in the end of the day, this billing thing, everyone can provide. Implicity provides automation for billing. Many companies does that. It's the starting, it's the basics, right? It's the first thing. And then you want to add other things. So my vision when it comes to universal platforms is, yes, you need reports, you need billing, especially in the US, And I'm happy the guidelines attract our attention on the alert-based and the quality of care as well now, and not just, the 90 days transmission. It's more complex than that. And I think Biotronic 20 years ago started this continuous remote monitoring idea where alerts are, what brings us to the patient with clinically relevant issues. And that's the second layer. You want to have your team be able to respond in a timely fashion to clinically relevant issues, not just hardware-based, but basically atrial fibrillation, for sure, anticoagulation, but there's a lot, right? And the more you're efficient on the alert side, the more you're able to address that in a timely manner, the best you're going to deliver care. But then is the third part, and that's the AI piece, the artificial intelligence, and there is twofold to this model. One is automation, which is basically saying, again, the same thing. Maybe, just maybe, but I'm pretty sure it's right, technology we provide, and many people provide, can help you with the same resource, with the same number of nurses that you trained, address better quality for most patients, for more patients. And this is exactly where we sit right now. We are in this spot where we won't get 10 times more nurses or technicians, but we still need to handle these patients. And the last bit is prediction. It's even more exciting. It's about how technology can help us do things we don't even do. So I'm going to focus on the first, to be honest, because that's the most important issue. So at Implicity, we started this journey about AI a long time ago. We are one of the companies around with the most advanced systems when it comes to AI. And what I call AI is not just, any system that is doing algorithms or automation. What I call AI is regulated AI. AI, usually when it's advanced, when it's machine learning, especially as Jack said, it's going to need FDA clearance approval. It's going to be a medical device. You want this to be safe. You want this to be, to have a performance analyzed before you use that on your patients. Because down the road, at some point, we may stop to review everything. At some point, when we trust the AI. So that's super important. So we speak a lot about AI. Sometimes we have this question, especially in Europe, do we speak too much about AI? I think it's the same we did for mobile phone and for the internet back there, 30 years ago. We speak a lot more about AI that we currently have. Everyone say they have AI, right? Every industry have AI, everyone. But we don't have that much. And I think we need to focus on approved AI, and it's very easy to check. You just need to check FDA clearances. So Medtronic has one. Implicity has one. Maybe there are others. I mean, cardiologists did a great job back there with Philips now. There's not so many, right? It's just a bunch of a few groups of people. But I still think that AI is going to be incredibly important because it's the only way we will fix this resource issue. So I still think that people speak way less about AI, but it's actually going to end up as a snowballing, basically. So it's like any revolution. So I'm happy we have some very people that actually understand what it means in this group, because that's not so many people. So you explain, Jack explained what we did with this ILR ECG analyzer. I will give you just another example of what AI can do in terms of resource decrease. And if I have time, I will explain what Suneet mentioned about disconnected patient as well. I may not have slides for this one, but it's fine. So we try to understand. So that atrial fibrillation alerts after ILR episode is probably the highest burden in terms of volume of alert deluge and volume of clinically relevant potentially alerts. Most of that, however, is not interesting. But you don't know it when you have the alert. You know it when you spend 5 to 10 to 15 minutes trying to access the patient file and understand if they have anticoagulation already, right? So it's a lot of time just to end with, oh, I don't care. So probably 85% of these AF alerts end up with medical intervention. No, sorry. So 85 is false positive, obviously, you corrected me. But 15% will be maybe relevant cases where you actually have to add anticoagulation and to do things that are very meaningful because you may prevent strokes and everything. So it's going, you have an evaluation of how much time it can mean. So you can probably find your numbers of nurses you need for 1,000 patients there. And a typical manufacturer system will send to you every week, every day, a lot of alerts for the same patient. But just some of these alerts probably matter. And we believe at Implicity, this is probably what you want to see. You don't want to miss the first one, right? Because this is when you're going to decide anticoagulation therapy. But then you probably want to know it's increasing. You probably want to know it becomes persistent. You probably want to know when it's back to sinus rhythm, which no manufacturers right now is saying to you. No one does. So you don't get that. If you get a universal platform, you won't get this information because it was never pushed by manufacturers. The only way you're going to get access to that is if you have access to discrete data. And then you have a smart system that is going to reconstruct the knowledge you have about your patients. That's what we call AI. So this is just a small example. We did that for smart alerts, and we are basically replacing 5 alerts from manufacturers by 1. But everything you're going to see is going to be meaningful. So this is designed to be used for anticoagulated patients, obviously. And if it's not meaningful, it's still going to be shown in the system, but it may, if you trust the AI again, it may be directly archived. It's going to be there, but you won't spend time on this anymore down the road. We proved that you can decrease by 78% the number of AF alerts. So when if you decrease false positive from ILR by 78%, and then you decrease false positive on the AF side by the same amount, it begins to be meaningful. Can I just get a few minutes more? Yeah, thank you. So everyone may think, whatever solution or platform I will choose, I will get AI, right? Because everyone speaks about AI, so everyone is doing that, right? So first thing, when Medtronic develops Acturhythm, you may or may not have to pay for it, but it's going to be there for everyone and for every universal platform because it's on the kerning side. So everyone is going down the road to get access to that data. When it comes to basic stuff, automation for reports, things like that, probably every company is going to propose that at some point. I hope so. We do, obviously. When it comes to advanced AI and machine learning and productivity gains down the road, you need to have FDA clearance. That means you need to have a quality management system inside your company to even start to work on it. And then it takes 2 to 3 years to get there. So you need a very, very strong commitment as an industry because it costs a lot of money to make this accessible and to achieve that. So, you have to decide whether or not you want AI someday. Because this is not just a new device, a new pacemaker. You need probably to, this is IT, so your institution is not going to be able to change the system every year. And last point I wanted to raise is just for this to work, to use AI, you need discrete data access. And we at Implicity spend a lot of time to be the most advanced company around to get access to not only the usual data that manufacturers push, but to things they don't push directly to us. If you don't get EGM, you cannot apply ILR, ECG analyzer, etc. If you don't get this data, you cannot apply smart AF alerts. So that's about it. Final thing, in the end of the day, I said before, we need to deliver the best care. We did that kind of work with Implicity, and we're going to announce Sunday morning as a late-breaking data about outcome of patients when using Implicity platform. Thanks a lot. I was a little long, but thanks a lot.
So thank you. So I have a lot of questions out here, and some have come through from the audience too. But if I can start with you, Suneet, we had these recent remote monitoring guidelines published. Anything on remote programming in there at all, or is it all just monitoring at this stage?
Well, I think that many of us are dealing with a recent device recall where we wish we had remote programming to solve the issue. And I think the guidelines are very favorable to wanting remote programming, but it's kind of stuck in a regulatory hurdle. We have some early experience with loop recorder reprogramming, but sadly, those are not the types of devices that typically need to be reprogrammed. So it's definitely a major unmet need.
Got it, got it. And Arnaud, if I can just chase this up with you, how much of the information, let me kind of rephrase that. Does Implicity have an intent to be able to share information with the patients? Is there, because we keep talking about self-management strategies in the future, and we may not want to delve into self-management, but self-awareness certainly seems like a good option. So any thoughts on that, where you are and where other remote monitoring companies are on that front?
Yeah, that's a great question. I haven't raised that, but so when I started 7 years ago, I thought, one patient has one device from one manufacturer, so it's probably the manufacturer's responsibility to provide them an app and feed them with the data, right? Because it's just one. It doesn't have to be agnostic or universal. But now, we just actually delivered our first version of an app for patients. So we believe now that, it's not just our responsibility, but we believe it's too slow. So to be honest, I thought it's too slow, and we don't see that many things going on the manufacturer's side, in my opinion. So we actually just finished 1 month ago an app for patients, so for both CIED patients and remote monitoring that we're going to release soon in the US.
Got it. So that's useful. I think it'll open up a whole different Pandora's box when patients start seeing their own data. What is something actionable, what is not actionable, anxiety-provoking or not. But I think it is the way medicine is going to progress. I think you can't always be patriarchal. You need to have them engaged and involved in the care too. So there are different companies have different ways of doing AI on the data that comes in, right? Some of the work that Suneet has done works off PDFs and works off the information that is garnered from the PDFs, and as a result of which, sometimes the information can get distorted. And also, you may not have the right algorithm that is translatable for another company's devices. And some places have direct digital access, and you have algorithms that work pretty well because you have direct access to the data. What are your thoughts in this whole remote monitoring world on these interoperability issues and also on different forms of AI algorithms for different forms of data?
Well,
You go first, and then Arnaud
I
after
mean, it
that.
seems to me like obviously any algorithm that has the actual raw ECG data is going to work better. I also think that the duration of AF episodes can be quite different. Sometimes you only have a few seconds of ECG information, and sometimes you have longer ECG. And just like the human eye is much better at the more you get, the longer the run of ECG that I have to see, the more confident I am in my adjudication of what the rhythm is. So I think that is going to be an issue. But then the other issue is that if a vendor has run their algorithm AI, the jury's still out whether a second layer on top of that Implicity or someone can run could maybe even further refine the process, and we don't know that just yet.
And would that process involve recorded ECGs or direct access to the data?
I think, Arnaud, you
Arnaud,
probably can answer that better.
No, that's a great point. I think cardiologs started to work, and they didn't have the same access to ILR data as that we got at Implicity from Medtronic especially. I think, like you, Suneet, that it doesn't make sense that the data is there, it's being recorded by the device, it exists in a raw format, and then it's going to be like printed in a PDF, and we're going to use that to treat patients out of a PDF through AI. It's incredibly dangerous because the way machine learning works, we know there's a lot of bias. We don't know exactly how it works always. And it doesn't make sense to basically run diagnosis on not the best source of information. There was a meeting yesterday from HRS about the working group from IDSTO standards. So that's basically the layer of interoperability for devices. HRS is doing a great job. It was joined now by EHRA, the European group, and all the other groups to basically, help manufacturers, I would say maybe push manufacturers to some degree to give more open data accessible for third parties. So I think this is moving forward. To be honest, within Implicity, I felt we won't wait for it because our responsibility is to get access to this data, and providers in the US can ask data to be available. Patients can ask data to be available for their care. So that's the main thing.
Got it, got it. This is a nice question out there, and it comes directly for you, Arnaud. How does Implicity deal with data that comes in from the clinic checks, and how does it compare with the competition like Merge and other companies?
Yeah, great question. Thank you. So yeah, that's great because actually, you need to come. So I haven't taken that. I'm sorry. So it's not planned. It's not a fake question. We have a new small box now, a USB box. You need to come on the booth over there to see it. We launched that 3 months ago in Europe, and we just got FCC clearance 2 days ago. So that's why I couldn't prepare for this. But we are basically able to export data from programmers and to get them in this box directly sent to the cloud. So within 10 seconds, it's accessible in our system. So I think it's quite unique, but we are able now to have all the data from programmers from in-clinic checks as well come to our system. When it comes to competition very fast, Merge is probably the company with the most volume, I would say, when it comes to reporting and billing system in the US. It's quite different. Merge focuses on having a reporting and billing system. We focus on, of course, dealing with, having a dynamic billing system, so you won't get stuck by the 90 days window. But we focus, as you said, to detect disconnected patients ahead of missing transmission. So we can even do a better job when it comes to billing. But in the end of the day, my vision was always to provide as well better quality, decrease clinically relevant information that we need to process with our staff, because down the road, we don't have resource enough. And Implicity was designed from the start to replace manufacturer's platform and have data flow inside it instead of being an additional platform.
Got it, got it. So Suneet, I have 2 questions for you, or 2 parts. your statement that came out from the remote monitoring, which you read, almost insists on clinicians taking ownership for their patients not connecting to the remote monitoring platform, taking ownership of their lives and saying, hey, you need to keep doing this. When do we draw a line in medicine that we say, okay, you're an adult, you can decide for your own, rather than, constantly plaguing them with asking them that can we be big brother for this issue?
Yeah.
Thoughts?
I think that's a very important point. I think that, to be clear, what the guidelines say is that the patient should be educated that this is the standard of care and why this is more valuable potentially for their healthcare than just a calendar-based office schedule. Now, if they don't choose to participate, and many don't because of financial reasons, there are many people who believe that sharing any of their data on the cloud runs against their beliefs. There are many reasons why people don't do it. That's okay. Then the second thing the guidelines say is that when it comes to connectivity, it is a responsibility that is borne not just by the clinicians, but that the patients and even the device manufacturers all have important roles in being able to identify who's disconnected, and they need systems to get these people reconnected. It just can't be on us to do all of that.
But where does the extent of accountability lie? For example, if a patient has a device, you warn them once saying, hey, get connected. The next day they're found passed away in their house and found to have ventricular arrhythmias that caused it, and nobody detected it or advised them accordingly. Is it the manufacturer? Is it the the intermediate universal platform? Is it the clinician? How would you look at that?
So it's a great question, and to the best of my knowledge, Jack, there have been no case precedent on this issue, and so it's really unknown, how any of it would happen. I will say that, having implanted thousands of loop recorders, we have unfortunately have loop recorder tracings of people who died in their sleep, suddenly, and it shows asystole, and it shows VF of people who've clearly had an infarct, and there's really nothing you're going to be able to do about that. The converse is also true, by the way, that there are patients in our practice who disconnect themselves manually to ask the question, is anyone even looking on the other end? And they wait for us to call them to say, hey, I was just checking to see if anyone's even looking on the other end. And that's another problem that we have to address, that patients have to feel like we're actually doing what we're telling them we're doing.
Got it. Arnaud, last question for you. I know we're running out of time. Why do we still have false positives? I mean, you're training your algorithms with hundreds and hundreds of thousands of ECGs, and every time you see one more patient, you have another ECG that could be used for relearning, and you have generative AI that can behave like a human now. Why are we still having false positives? And not a trivial amount, a certain specific amount, especially for AFib and short duration. I mean, why is it not getting fixed, or where do you think the problem lies?
So, first thing is we saw a lot of things moving in the last years. I mean, the simple fact we actually have now FDA-cleared algorithms to process that, I think, is a great news. I think the reason is that we want to have access to more data. Liability on the manufacturer side doesn't incite to be extremely specific, obviously, but down the road, as clinicians, we are going to ask always more data. And if you ask, if physician could have a single recording through ILR of 3 years of data of patients, they may ask for it. So we probably, as clinicians, want to have the most we can, and then we realize we cannot process it. So I would say we need to find the balance, but the more AI we're going to have to be more specific, the more we're going to open the pipe on, to have more and more coming through, and we are going to learn, and we are going to find new phenotypes and new diseases. So I guess it's twofold. We need to understand that we want more as well. So we are part of this issue, I guess.
Great. Well, on that note, I'm going to thank both the speakers. Thank you, Suneet. Thank you, Arnaud. It's been a terrific session. Thank you all for being here.
Thanks, everyone, for being part of it.